and health system-based communities, as those can be a little bit more challenging as a layperson or community provider to get into than, say, some of our other government or public agencies. Next, based on some feedback from an earlier webinar, just kind of some thoughts and updates on the legislative landscape and background on what is happening with the controlled substance reporting system and how, as a prevention community, that could be a really great tool for you, and then some other options there in addition. And then lastly, I'm going to talk to you about a use case of how we here at the Healthcare Association built together a coalition of about 130 statewide partners that range from law enforcement, hospital and health systems, local and federal governments, and community health providers, all working around specific areas of focus to combat opioid efforts on a system level statewide. Now, a lot of these efforts are not necessarily prevention focused, but they do have components that you could take back and maybe a way for you to engage. So that being said, throughout the whole webinar, it's really, really important to me that you get the most out of this. So I'll be constantly monitoring the Q&A box. So if there are things that you hope to get out of this, if there are things that you feel we need to spend a little bit more time on or have questions about as I go through, please type those into the chat box, and I'll make sure to answer everything before we end today. So that being said, we're going to kind of move through to understanding the medical community and where you fit in. And I think sometimes it can be a little intimidating. I know for me, speaking personally, when I first started here at the Healthcare Association, I really didn't have a ton of experience working with our health systems and figuring out ways to get engaged with them, and how do we get top-down buy-in from these large anchor institutions that really have the opportunity to benefit a lot of groups was something that I was challenged to think through and really focus on. And what it came down to was understanding my place in relation to everyone else. And it's something that prevention workers and community-based health workers and nonprofit understand really well. It's that notion, we talk about it when we deal with special populations around people-first language and reducing the stigma. Yet sometimes when we are approaching doctors or hospital executives or healthcare providers, we don't necessarily view them in the same light and don't necessarily take the time to consider where they're sitting. And that was something that kind of, when you hear it, is like, well, no duh, but when it clicked for me, it was one of those aha moments that really allowed us to expand our footprint and reach into all sorts of groups that we had never previously engaged with, from needle exchanges to law enforcement agencies to the LME MCOs to various EMS transport systems. Those are all different groups that we've been working with closely over the past 18 months to create a systemic plan of action of how we can coordinate efforts to tackle the opioid epidemic. So as you think through this, think about your personal community, think about your county, and think about your position in it in relation to those various stakeholders. So as we move through, you and the opioid crisis, and please chat in the box, what is your perception? As I said earlier, wasn't expecting 95, so this was initially planned to be a little bit more interactive, but we can still do this via Q&A. So what is your perception of the opioid and prescription drug misuse problem in your county? And I see the sound. Is everyone having trouble hearing me, or is everything okay? Access, absolutely. I think that is an issue that we are continually dealing with over and over again here in North Carolina, is this notion of access. I think everybody understands that the solution for the opioid or prescription drug epidemic that's coming down our way is not one, but many. And we have continually refrained from thinking about how do we provide prevention and treatment programs for patients in the community. That's absolutely right. That access piece is critical. All right, great. Sounds like hear me well. Yes, the perceived low risk of harm. I think that's another real critical component. Lately, there have been efforts to talk about the risk of the prescription drug that is being given out and in the quantities they have. I think we've seen over the last 12 months in particular a concerted effort from those in the prevention community to really tackle that head on. But I think one of the key areas when we talk about engaging stakeholders and sectors that need to be engaged with that is the new patient in the critical settings. So how are our primary care physicians who don't deal in pain medicine, our pain medicine docs, our emergency room docs, even our inpatient facilities are being inundated with thoughts and feedback around how to mitigate prescribing habits. And our primary physicians, honestly, are asking for tools and are asking for resources to help them, because this issue has blown up so high, and it is such a, not only is it a critical health issue, it's also a PR issue, if we're going to be honest. And I will be very candid with some of the comments and thoughts here that with stigma and with this, finances, perception, and public relations are just as critical to affecting change than just making sure people are healthy. And I know that may seem cynical or may seem a little heartless, but I think we have to be honest about why this became an issue in the first place. So, yeah, translating jargon between disciplines, I think creating more of a uniformed language is really vital. And we'll talk about, actually later, that there's some tools and tips to work through jargon and how we can frame some of these conversations a little better. The perception that patients are vastly more worried about patient satisfaction than the overall well-being of patients. You know, that's a really, really interesting point, and I think that's where the disconnect really lies. Most doctors, and especially your primary care physicians and your community providers, they went into medicine because they wanted to help people, just like you, and just like me, and just like all of us. And so that is a real perception that we have to ask ourselves. And really, this is more of a stigma reduction effort on, if you want to think of it that way, from those outside of the healthcare community looking in. We are very ready to afford benefit of the doubt and trust and goodwill onto those that are in active recovery, those that have been affected by crisis of substance use disorder. Yet when we look to those providers who are expected and required to treat and manage and receive these patients, we don't often return that benefit of the doubt to them. And it's really hard for a person, regardless of the situation, to be empathetic to another's situation if they don't know they are they're cared for in the same way. And so even though these doctors are required to care for patients, their well-being and their view and their personal satisfaction is important, and our ability to ensure that we're empathetic to them and that they are viewed as they see themselves is healers. And while let me be very clear, there are lots of times where that can be very frustrating and challenging and annoying, for lack of a better term, but I think that return of empathy is going to be critical. So successful in engaging the health department, that's great. Challenged with VA clinics and hospitals. I think that is going to be pretty common, and hopefully we can give you some tools to think through that. One of the greatest resources you have is your health department. And the reason that is most of you are familiar, and if you're not, your health department is definitely familiar with the community needs health assessment that is required to be done every few years. And actually, 2019, luckily, is the next year that that's due federally, and that is part of the Affordable Care Act. It's not going away, that where the anchor institutions, hospitals, health systems, those large bodies, have to create community wellness plans in coordination with each other. So, for example, here in Wake County, we have a steering committee that meets, that has different groups and includes our 3 major hospitals and then all sorts of different stakeholder groups, from the YMCA to Wake County Public Schools to crisis hotlines. They all are engaged, and what we're doing is we're trying to get a survey of what are the needs and where are the needs in our community. And then there's a report that's published. So you can actually right now go and look at your county's community health needs assessment. You can search, Google it, and you'll be able to see exactly what they did, who they engaged, and even the people they engaged. And that's a really great place to start. Pharmacies, EMS schools, health department, law enforcement, challenge with pain management providers, and faith-based communities. Great. I think those are all different groups that we have to think through how do we engage them. And the easiest and hardest way at the same time is by using a conduit. So I guarantee you that if you spent 5 minutes and listed out those provider or those entities that you're struggling reaching and the entities that you are successful reaching, there are people that you have great relationships with that know somebody or have a connection with people in the areas you're struggling with. And using the people that you are greatly successful with to help build that bridge is really important. You're more likely to take a phone call from a friend of a friend than a cold call. And so if you are introduced via someone else, it's going to be a lot easier to make that initial engagement. So moving through, so why do we work with them? I think this is the question. I think it can be challenging. I know it can be challenging and frustrating to work with hospitals. It's what I do every day. If my boss or provider group heard me say that, I could get in trouble, but it's the truth. There are bureaucracies and red tape and challenges that go with working with large institutions. And it can be frustrating because it can seem like a small change that just needs to be made in one spot, but it's going to take 6 months. And you have to ask yourself, is the change worth it? And if it is, you keep pushing and you take 1 step forward, half a step back, 2 steps forward. I think we have to be okay with better. It's called better because it is better, and sometimes we look to be perfect or we look for this giant solution. But if each of us go step by step, little by little, and just get a little bit better in those relationships or in that conversation, then before you know it, you'll look back and you'll realize you're a lot further along than you thought. So I am not going to read these slides to you. I'll make sure that they're available to you. I really want this to be more conversational. So as you're reacting or hearing anything, please continue to engage. One of the things I do want to point out, though, and it's going to be interesting in the next kind of bit, is this notion and this idea of doctor shopping and helping to understand your patients and your clients and how they are utilizing the medical system and how you can then translate that back to a provider. What a provider wants to know and what they're tasked with really doing is figuring out how to ensure that their patient doesn't see them that often. It's actually better if a doctor doesn't see you because depending on the situation, it's a very costly expense. Now that doesn't mean they won't, or that doesn't mean they shouldn't, but if we are all doing our jobs right, upon discharge from the hospital, there is a link to you that can then be connected and ensure that that patient is following that right track. And right now what's happening is there is a closed system of community-based prevention and providers that ensure that a patient is following along a track, and then we lose track of that patient. And when we lose track of that patient, they kind of fall in this hole. And then they pop up in an emergency department. And they go through another cycle until they're discharged. And when they leave the emergency department, they fall into that hole again, and you may pick them up. And then they'll go through your cycle until you lose them. And they'll fall back into the hole, and they'll have a crisis episode. And eventually they'll either continue to cycle through that, the prevention community will figure out a way to ensure that they're successful, or sadly they'll pass away. And that's really, if you look at it over and over and over again, that's what we see. And so the question becomes, if you see a patient that's continuously cycling in and out of your services, more than likely they're circling in and out of the health system and health provider services as well. And so identifying those patients and making a use case around how can we ensure that we know when this patient is in either of our systems is the most effective and I think the most impactful way that you can build that partnership with the healthcare provider. Now that's going to take some legwork. It doesn't need to be these, and when I say that, people immediately jump to, we have to get EMR and we have to link our EMRs together. No, you don't, and there's different solutions. I'll tell you anecdotally, one of the best public health / prevention projects I ever got the chance to work on was in Africa, and it was the most impactful study that we did, and it was around nutrition, and it was around ensuring that mothers were collecting data, mothers were making sure their children were fed well, and what we saw was that initially we were really struggling capturing outcomes, and we were really struggling capturing what was happening, and we had people in the community, they had tablets, and they were doing all this stuff, and it just wasn't good enough. And so we asked the locals, and basically what we did is we set up a mailbox with 3 slots, and you dropped a pebble in a slot when you picked up your food, 1, 2, or 3. And through that, we saw that the people that were dropping their slots in the 1 were less healthy than the ones in the 3, and there were some other reasons why they drop it in those 3 slots. But it was really a rock in a box. and that gave us more valuable outcomes than anything our Tableau and analytics was able to give us during that project, and we were able to make some significant changes. So I don't say that that's going to be the exact way. You're not going to be able to set up a mailbox where you drop rocks to figure out this problem, but it is to say that the solutions that you're thinking of don't necessarily have to be so robust and technologically advanced and expensive that they're not feasible. Someone says, some hospitals in my community are linking health records through EHR. This helps with past patient medical history. Absolutely. There's also another service called Patient Ping. And what Patient Ping does, and a lot of our hospitals and health systems are linking up to it, but it also goes out into the community and links up with homeless shelters, links up with community providers, links up with care teams, and a patient then gets assigned to a doctor, and when that patient arrives in any of these other facilities, they get a ping that, oh, so-and-so went to this place. And when they get that, that provider also receives a notification when the patient goes to any of their other places. And so you're really able to kind of get a wraparound care in your community. And it doesn't share PHI, and it doesn't violate HIPAA. It really is just tracking. And so if we can start with those little tracking pieces, then we can really move forward. And if you want more information around that specific entity or service, you can email me. I'll have my contact information at the end of the slide, and I'll make sure Jamie shares it with you all. I'll be more than happy to talk to you more in depth, but I don't want to spend too much time on that. So, there's a lot of benefits to working with them, and I think you guys are hitting on some of the key reasons why. But I want to shift gears a little bit. We'll come back to this because a lot of what we've talked about, linking and understanding and following movements, have been kind of part of some legislation and some kind of policy places. And one place where the prevention community and where folks have a massive opportunity to build a relationship and help foster growth is in the policy and advocacy arena. And I say that in that helping advance the causes of institutions and organizations that are similar or are serving the same populations as you is a great bridge builder for collaboration. So I'm going to talk to you about the stuff that's going around the opioid epidemic in the state. Some of you may be familiar with this. Some of this may be new to you. I will try to keep it high level. If you do want more in-depth, we can talk about it. Just ask questions, and I'll be sure to go in. I am, full disclosure, a policy wonk, so I can get really in the weeds in this. So please tell me to come out if you feel we're going too deep and this isn't really relevant. So kind of a legislative background of the state of the state. North Carolina is very much engaged in the opioid epidemic, and it's viewed as a priority from the governor's office to the legislature to the attorney general's office. It is one of the only issues in the state that I can think of that crosses the aisle. There are multiple bipartisan bills that affect really, really solid changes. If you told me that North Carolina would legalize syringe exchanges with the General Assembly we had 5 years ago, I wouldn't believe you, but they did. And your community and your county can legally start one and start doing harm reduction and different types of programs. Similarly, there are Good Samaritan laws if you call someone who's been in an overdose. There are the STOP Act, which puts prescription limits on initial opioid prescriptions in the emergency department and outpatient setting and surgical settings. There is controlled substance reporting, which does a lot of that. It tracks a patient anytime they get a prescription, where, when, how much, by who, that the doctor can then go check before they prescribe and see, oh, you know what, this person's gone to 4 providers, or this person's done X, Y, and Z. And so a lot of really, really good shared outcomes has started to emerge through this issue. And so thinking about what are the critical needs of your community, what are the ways that you can advocate together for change, because as our emergency departments are becoming inundated with behavioral health patients, our community providers, the reason is you all don't have enough resources to provide the right services adequately for as many people as you should. And that's no fault of your own, and I think there's a lot of synergy and opportunity there. So first, we're going to talk about the prescription drug monitoring program. And it is in North Carolina, it's called the CSRS. If you go to any national conference or you talk to people in other states or others, you're going to hear the term PDMP. It's the same thing. The reason North Carolina did controlled substance reporting system is really kind of silly, but number one, they said prescription drug is too vague. I don't really care about your Z-Pak or your antibiotic for the flu or whatever it was. We really are trying to target your controlled substances. That's what we want to track. Number two, they felt monitoring was a little bit too watchdoggy, given that big government in the eyes of our General Assembly right now is a little bit, that's not their preferred method to solve solutions, so they decided to use a reporting system instead of a monitoring program. Same thing, but kind of understanding how we got to those words and understanding why specific words are chosen can be helpful when talking about it to key stakeholders. So, but basically, a clinician prescribes a drug and sends it to the pharmacy. The pharmacy, when they fill it, reports the prescription into the system. And the doctor, before prescribing, can check the system to see the patient's relevant history. Hey, please make sure you're on mute so that we can continue to move through. So what you can see is if you go to the DHHS website, you can go and check CSRS utilization by county. And the darker, the higher utilizers, or the more people are using it, and the lighter blues are less folks that are using it. And honestly, you can expect that darker blues may be in more populated areas. But if you look, the counties around Mecklenburg actually have higher utilization than it. And so it's not necessarily population-driven. And I think a great educational tool and a great way to engage your medical community is to talk to them about the importance of checking the CSRS before making a prescription. Now, this is key. Doctors don't like being told how to do their job. I really don't know any profession that likes being told how to do their job. And so what we hear a lot of times, and fortunately we're not in a room, but if you raise your hands, I bet there'd be a lot of hands in the air. How many of you feel we have an over-prescribing problem? And you can type yes or no or, you know, one word into the chat box for the Q&A. But what I've seen is, and Ashley, yes, EMS is, CSRS is linked to state to state. And Michael, I will definitely get to your question here in a minute. But what we've seen is, yes, we're talking about an overprescribing problem. I work in an ED, and yeah, dentists do. Actually, we'll talk about some of the the groups that are carved out and what we're doing to fix that. But yes, they do, and I think that's a great way to engage as well. But what we don't have, and this is critical, is we don't have an overprescribing problem. We do, but we don't. And the reason I say that is because I didn't go to medical school, and so it's really hard for me to tell a doctor how to prescribe. What we do have, though, is a safe prescribing problem. And when we shift the conversation and ask a doctor about talking about safe prescribing measures rather than telling them they're overprescribing, their body language and their receptiveness immediately shifts. And it's one word. And so as you look through your issue areas, how are you framing them? That's a really, really critical component of engaging stakeholders, of convening hospitals or bringing doctors and bringing those people that you don't necessarily have to the table. We can view and we can see and we can run reports and know who is a high prescriber and who is a low prescriber. But nobody is technically over-prescribing. They're prescribing unsafely. And that's a much easier conversation to have than to tell somebody they're doing something wrong. And it's semantics, and you may roll your eyes or you may think that's not really that different, and it's not. But those subtle changes as to why is it the Controlled Substance Reporting System Act that got passed and not the Prescription Drug Monitoring Program Act that got passed. Those subtle words and those subtle changes in how we talk about our problems and how we talk about them with people we are struggling to engage makes all of the difference in the world. And I challenge you to make a list with your teams about the stakeholders you're struggling with, the problems you're facing, how you're talking about those problems right now, and what are the ways you can change it just slightly where you're still talking about the same issue, but you're framing it in a way that they are willing to listen. And that doesn't mean they will. That's not saying that, oh, as soon as you start talking about safe prescribing, you're going to get in the door. No, but it gives you a better chance. All we're trying to do is give you more tools to be a little bit more successful. Yeah, Teresa, you're absolutely right. CSRS, it allows providers to verify what, when, who. It is a really good check and balance, and that's a great way to put it. Great. So people ask about dentists and state-to-state linkages. So additional supporting data, we have NC Detect. You can actually get county reports. Since actually in the last day, I hadn't had a chance to update these slides in the last 24 hours, but the state has now put up the opioid tracking dashboard. You can search for it, the NC Opioid Action Plan dashboard, and you can actually go look, and there are really compelling numbers and cases that so you can drill down to county, and they'll give you charts and graphs and numbers of your county's ED visits, your county's death toll, your county's literally number of pills that have been prescribed in your county. And you can kind of see how it's going. And if you see an upward trend, that's a really, really strong use case to engage that stakeholder, because we'll see soon that if doctors and clinicians and pharmacies are not actively utilizing the CSRS and are not being adherent, they can face some harsh penalties. And I think you as a prevention community stepping in and helping them before they get penalized is a really great avenue to explore as well. State-to-state linkage actually just came out in the last 3 months. Some technical pieces about it. The CSRS is currently under contract through the end of the year with one provider. It is being explored on how that's going to change and if there's going to be opportunities for other linkages. So the website, and I'll make sure to send a link, but it's basically the NC Opioid dashboard. So I will paste the link in the chat box for you all. You can click there, and you'll be able to see the action plan. You'll be able to find your county, and there's some really, really cool graphics and numbers and state level that you can then use to talk and build some use cases out. NC Detect is another tool. DHHS, the Injury and Violence Prevention Branch, Epidemiology, they're ready and willing, and your health departments have access to them, and they really, really want to provide useful metrics for you. And they are a great resource, and they are also a great connector. As the state has taken a more active lead in the opioid epidemic, they have also set up a lot of coalitions and groups. And if you're struggling to reach certain sectors, they can make some of those connections for you, and they would be, I think, happy to. So kind of moving along, the STOP Act is the main piece of legislation. And what it does is it limits the prescriptions of first-time targeted controlled substance. And that doesn't mean like if I've gotten like 7 prescriptions from different providers that I can get whatever I want. If it's the first time I'm seeing Dr. Jones, he can only prescribe me less than 5 days. And that is in any setting other than the surgical setting. In a surgical setting, they can prescribe up to 7 days. So post-surgically, you can have 7 days worth of medication. There's some really cool projects going on across the state to see if those numbers make sense. They're a little bit arbitrary, but they're a great start and have really lowered our overall prescription habits in the last 12 months. Talking with some folks at the state and some other partners, we've seen a marked reduction. Actually, in the NC Medical Journal coming out, there'll be an article outlining some of that I wrote, that you can kind of see how this act and some other things that you're hearing about today have actually shown some behavior change in our prescribers. And I can be sure to share that article with you all after as well. So the STOP Act and the CSRS. The STOP Act requires prescribers to check the CSRS before the first time and every 90 days if they're an ongoing patient. So best practice would be to check it every time you're going to prescribe an opioid. Workflow, we all know if you're adding one more thing that I have to do before I can finish this case, you're going to drive me insane. That's no different for a doctor. And I know what you're going to say, and I've heard this argument before, is that, but Jay, it takes 2 minutes, it takes 3 minutes to check the CSRS. And you're right. We actually did a click study where we followed we'll get to that. How is checking monitored? They actually have to log in, and so there's a record of every time they search, and then the back end actually has a query system, so they'll run a report for the medical board that keeps track of that. So that's how it's monitored. It's through the licensing body of each field. So as I was saying, the 30-day, 90-day checks, I totally lost my train of thought after that question. So we're going to kind of move on, and if it comes back to me, if one of you remembered where I was going, please type in and let me finish that point. It also requires that PAs and nurse practitioners personally consult with their physician before prescribing. Now, That can be a challenge in some rural communities where the nurse practitioner or the PA is the only person in the clinic issuing prescriptions. However, it is a key piece, and that personal communication can be via email, text, phone. It doesn't have to be face-to-face, and we've seen that this change has been, has been actually an effective way to lower cases. So back to what I was saying, minutes per click. To check the CSRS, on average, it takes a doctor 2 to 3 minutes to do that. And that may not seem like a lot of time, but when a doctor is being required to see 20 patients a day, and they have an average of about 20 to 25 minutes per patient, taking roughly 3 minutes on top of that before they do any of the charting and paperwork adds up really, really quickly. And so you expand that to the number of doctors that are seeing patients across our medical community and how much time and money that actually ends up costing. We have to think of a way that we can expedite this and make it part of workflow. And so there's really unique solutions, integration efforts and opportunities, and that's part of why the state's looking at a new vendor to make this process faster, because it is so important. So before we get in a hullabaloo about 2 to 3 minutes about something, think about how many cases you're seeing a day, and if your day extended each case by 5 minutes, and what that would look like by the end of the day. And that, I think, is a way to kind of get some empathy for some of the tasks on both ends, because you're going to be asked to do things, and more reporting and more documentation is frustrating, and it can be really important, but it's still, we're all human, and we all get annoyed when you get asked to do one more thing, even if it's really important. And so it's about that understanding and knowing that, hey, we're going to get there, we're going to figure out how to make this work, but this is critical. And part of your safe prescribing options is doing this type of work. So another piece, Stop Act, it requires electronic prescribing of controlled substances. Right now, we don't e-prescribe controlled substances. They are called in or they are handwritten scripts. And that is a security measure so that someone can't. But what we've seen, and that was an antiquated security measure that was actually more secure before our back-end EMRs got set up. However, this is effective January 2020 because in order for me to e-prescribe, I can be on an EMR, but if my community pharmacy in Columbus County or my community pharmacy in Murphy, North Carolina is not on EMR, how am I going to send them an electronic prescription? If rural broadband is a challenge, they do have doctors that can check and print the report. However, what we did in our research was the actual time the physician spent on the CSRS, because printing and searching and clicking is part of it, but then actually reviewing the report, and then it's not as, honestly, the current interface is not very user-friendly, and so there's a lot of back-end pieces that are being done to clean that up, Ashley. But that's a really, really great point, and I think that's one way to share. Yes, all of these slides, are going to be, we'll make sure to send these to you. Yeah, actually, we will get to that, Deanna. That's a really, really great question around stigma-related issues and how we are addressing that. That's a perfect segue to our next section. So kind of just generally, we're doing really well on time, but I want you guys to think, how might you be able to use this STOP Act and the CSRS to be more effective in supporting your clinicians? For example, we all know that checking the CSRS is important, and we all know that this is a critical piece to ensuring that we have safe prescribing. But if a workflow issue and we need to advocate at the state level or at the policy level to make the CSRS more efficient, how can you, and this is just a rhetorical question, partner with your agencies to say, hey, we as a prevention community also support our hospitals and our health systems in seeking a more efficient connection to the CSRS. And in return, the hospital and health system will greatly appreciate having a diverse stakeholder group to advocate on their behalf, that when you have issues, kind of that you scratch my back, I scratch your back piece. So think about that. Think about the prevention problems or prevention issues that you may have that you need support from a larger body, or if a hospital or if some other entity was like, yeah, we actually think that's a great idea too, and we support this, how helpful that would be. And when you're a large entity, having other smaller and other diverse groups saying, no, this isn't the big bad guy, we all agree to this, is also powerful. So this two-way conversations and this two-way opportunities for policy exchange, I think, is a great way to really bridge that gap. So next, we're going to just talk a little bit, I'm going to talk to you about some things that are around the state, and the Coalition for Model Opioid Practices is a use case example of how we here at the North Carolina Healthcare Association are addressing some of the issues you saw before and are working to convene stakeholder groups so that they're all actively participating in this, because if anyone tells you they have a solution for the opioid crisis, they are lying. There is no solution for this, but there are multiple solutions, and we can all play our part. And if we all figure out what our gap is that we close, then that's how we get to a better and healthier North Carolina. It's not going to be some magic wand or some one thing that changes everything. And so bringing together people and connecting with people we don't traditionally work with is going to be important. So the state of mental health in North Carolina. This is a little hard to read, but there is some awesome information that I think is really important for you all to have. Number one, in North Carolina, after the recession of 2008, everywhere in the country decreased funding for behavioral health. In North Carolina, we're the only state in the country that's continued to decrease funding every single year since. Some states have plateaued. Some states have started increasing funding again as the economy has rebounded. But through the latest budget, behavioral health per capita funding has been cut. There's been unfulfilled promises of the Mental Health Trust Fund that would be used for community programs and has been spent in other ways. In 2012, you can see there were almost 20,000 people that were seeking help for a mental health diagnosis in an ED, and a repeat visit rate of 27%. That's astronomical, and that number's actually gotten higher. We've lost 54,000 community mental health providers, while the population in North Carolina has grown to be the 10th largest in the country. We're forecasted to spend $280 billion in 2020. We were at $170 in 2009. And the number of state hospital beds has decreased over the last 20 years. The prison population has boomed 64%. So while you feel the crunches and you feel the frustration of this problem acutely, so do your law enforcement partners, so do your hospital partners, so do your LME MCO partners, so do your local governments. Everybody is feeling the burden of behavioral health in their setting.
And so if we shift the blame to one group or one area, we're doing this a complete disservice. If we think about how we can each make this a little bit easier on each other, we can do a world of good. And what we're doing right now is we shifted the burden onto law enforcement and the prisons, and then now we're shifting it into the EDs, and the community providers are cut. And so each of us are ballooning in this population, yet everyone is kind of so caught up in their own area that they're failing to see the forest for the trees, and they're failing to see how much this is actually affecting our partners that we don't think care or that aren't receptive just as much. They're just as underwater as you may feel, and so that's why they may not be responding. And so to understand that state, I think it's really important to understand where and how we can talk about this and how we can have an open conversation. Because when we all start from a place of understanding that this is hard, we're more willing to listen to each other rather than, my stuff's hard, but why don't you help? And I think we have that happening a lot. I think if you look honestly at yourselves and look honestly, I know I did, it's very easy to point fingers or get frustrated and be like, well, what are you doing? You're a hospital. You have billions of dollars. Well, no, maybe they don't. Or maybe you're an LME MCO, and why aren't you helping? You're supposed to be. And no, they're doing everything they can in their community too. And why is law enforcement just jailing everybody? And North Carolina has the highest number of CIT-trained law enforcement in the country. And so our law enforcement partners are actually accurately and acutely aware of this issue and are taking steps to address it too. So that's a really, really important piece, and it's really eye-opening to me when you see it laid out that way in relation to where we each sit individually. 38% of patients with a primary substance abuse diagnosis have a secondary mental health condition. Almost 40% of the patients who come into our EDs are struggling with some sort of substance use and mental health dual diagnosis. That's so high. And if we are only treating the opioid epidemic, we are going to fail. I'll tell you, as you talk about this to your partners and as you talk about this to your communities, you're only talking about opioids. You're doing your community and your partners a disservice. I shared this with our coalition group story a few weeks ago at our last coalition meeting, and I'll share it with you here. I was at the grocery store, and I was walking through the grocery store, and some lady knocked a tomato off the tomato pile, and it hit the floor, and she just kept walking, and I was like, oh, so annoying. So I picked up the tomato, checked it, no bruises, and I put it back with the tomatoes, and I went about my grocery shopping, not thinking anything of it. And then I was leaving the grocery store, and there was a homeless man with some clear substance use or mental health issues asking for money or anything, and I just completely ignored him, got in my car, and was driving home, and I'm like, holy crap, I think I care about tomatoes more than people. And as I started thinking about it and really breaking it down, it dawned on me that a lot of times we try to just take care of certain things that are easy and not really think about how we do this work. So I didn't pick the tomato up and throw it in the trash or put it on the cereal aisle. I put it back in its rightful place. And we sometimes say to our patients, you need to go here. You need to be here. And as a prevention community, I think you all have a really great opportunity to help the medical community understand that what is that rightful place for that patient. And it's not the ED, and it's somewhere in our community. And so helping tell that story and helping somebody like me who spends my day working on opioid policy and spends my time working on behavioral health issues and healthcare issues at large, to realize that to understand where these people and where people fit differently in our communities. What are their rightful homes? What are their rightful places? We don't do a good job talking about that. We only try to focus on the work, and we really have a bad time telling the story of right place to end up. And how can you, as a partner, help the emergency room take that patient to the right place? How can you as a partner help that primary care physician understand where their patient is when they're not seeing them? That family doc who has grandma who is on pain pills, but her grandson's stealing them from her pain cabinet. How do you help that primary care doc help understand that situation and talk to him about diversion and talk to them? I think you guys have that story, and you got to leverage it appropriately. But thinking about compassion and thinking about empathy and thinking about why we all got into healthcare, it's to make sure that people are safe and that they are in the right place. And really, honestly, sharing that with each other can be powerful and meaningful and give you the confidence to build those bridges. If you don't have a story, find one. I guarantee you there's a story. Have one ready to go that you can share at a drop of a hat to anybody and tell it to everybody. Make it so it's like, oh my God, we're going to hear this one again, and surprise them with a new one. But tell your stories every time you get a chance. I don't think we do that enough, and I think that's the only way we're really going to get through some of these challenging conversations and these challenging pieces, because we get caught up in the logistics that we sometimes forget that this is about people. It's not about an electronic medical record or a medical health record number that's moving between places. It's a person, and stories connect us. That is critical. Some more harrowing images as we go through. The last 5 years, emergency visits has increased 105% in North Carolina due to opioid-related visits. In the same time, we had the highest increase in inpatient stays in the country. So that rate of increase, the 105% of just ED visits, has resulted in a marked increase in inpatient stays faster than any other state in the country, faster than West Virginia, faster than you name it. And so the burden is shifting to all of us. And so to understand where the pain and pressure points of our health systems are allows you to effectively talk to them about their problems and how you can help them solve their problems, and in return, they can help you. So with that, what are we doing about it? Well, somebody asked a really great question. How is the North Carolina Healthcare Association and others addressing stigma issue? Number one, we just launched an RFP, and next week we'll be announcing 6 EDs across the state where we'll be embedding peer support specialists in the emergency department to connect to community providers. So a patient shows up with an overdose, and they connect that patient to community providers. And the goal of that is to show hospitals and to show the state that this program is effective, and we need to be using peers and alternative partners in the care team so that we can then ultimately get a Medicaid service definition for that and expand that to other regions of the state, and ultimately it becomes normal that peers are in our hospitals, that peers are in the ED. That's not going to happen overnight, but this is the first step. And so we will be launching that. There'll be a press conference next week, and it's really exciting that our hospitals are like, yes, we want this. That was one of the hardest decisions, was selecting the sites. I had to go through applications from hospitals across North Carolina to select 6. But this can be done everywhere, and once we start showing some of the cost efficacies of doing this in more places, hopefully this becomes routine. It doesn't just have to be reimbursable. We can also, there's 2 ways to make money, right, or make profit. You can either grow your market share and get reimbursed more and make more money, or you can save more money and spend the same amount or spend a little bit less. And if peers are preventing rehospitalizations and are preventing readmission, they're going to save the health system money, so maybe cost effective to just do it anyway. We think that'll work, but we have to prove it. And so we're doing pilots like this and doing other things that really can get after that. We are working on legislation. We're in meetings right now to think through how we can better use our communities, create community crisis plans where hospitals, health systems, community providers, law enforcement, county governments, LMEs have to come together and create crisis plans on how to care for the IVC patient and ensure that they're moved through the system properly and effectively. And we really want to enforce behavioral health parity. For the last 10 years, parity has been the law of the land federally, but not enforceable. You're supposed to be getting paid the same amount for a mental health visit as a physical health visit, yet in North Carolina, you get paid 52% less if you're a behavioral health doc. That's not fair. And you can be a primary care physician and bill for the same thing and get paid 52% more. No wonder we're losing providers and we're losing people going into the field. We have to figure out ways to enforce that. How do we get insurance companies and how do we get Medicaid to adhere to those federal standards? It's part of our law. There's just no enforcement mechanism. And so those are some hard questions that are not easily answered that we have to think through. And so these are things that we're working on. And ultimately, this is really hard to read, but it's also on our NCHA website. But this is a coalition for model opioid practice. And what we are doing is we have convened 130 folks, and there are 3 work groups: prevention and safe pain management, the health system response, and healthcare worker diversion. We are so concerned about this problem that we overlooked one of the most vulnerable populations that have the easiest access to prescription drugs, our workforce in our hospitals and health systems. We created a work group that is specifically looking at how everyone from the receptionist to the CEO of a hospital can participate in employee wellness, upstream prevention efforts such as good diet and exercise, and know what resources they have if they suspect a coworker, friend, or family member is at risk of some sort of prescription drug or behavioral health issue. The Health System Response Group is working on stigma reduction efforts, conducting a workforce audit to understand what the actual workforce thinks of this population. I do this when I talk to hospitals and health systems executives all the time, and I said, how many of you are doctors? And the hands go up, and I said, how many of you, if you got a code blue right now, would run out of this room and go deal with it? Hands go up. I said, how many of you got a page that said, hey, we have an addict walk in the ED, would run out of the room and go deal with it because they're in a life-threatening situation? And maybe 1 or 2 hands go up, and they let them look around. I said, someone who's coding and someone who is in an acute crisis of overdose, they're the same person. They're both facing a medical emergency, and we have to start talking about this issue as a chemical imbalance. Addiction is a chemical imbalance in the brain. The brain is the only organ we refuse to treat as another organ. No one's going to tell someone with high cholesterol that it's their fault they ate too many burgers. You're going to get them their omega-3s and their coronary bypass surgery, and they're going to be like, oh my gosh, I hope you're doing well. Yet we don't talk about how this neurological chemical imbalance is causing behaviors. So I think we are working on that as hospital providers and as those that engage the community a little bit more closely. I think you all have an opportunity as well in all of these sectors. We're always, you can go on, again, our NCHA website and has links to the group. If you want to participate or want to get more information, you can find all of it. There's a resource page for community providers on there in rural hospitals on language. No, they're not crazy. They have a behavioral health condition. No, it's not an addict. They have a substance use disorder. You wouldn't call someone fat as a medical condition. You know, why do we use terminology? And I think there's opportunities there both ways. Like I was talking about, we're not over-prescribing, we're safe prescribing. We are looking at whole person care. It's not, why don't you care about this person? And so thinking about those things, I think there's really great things there. Lastly, this is just a question to consider. You can answer here, but like we talked about, your experience, how do you leverage that to connect with the medical community? And what supports do you feel like you need? I'd be really curious if you feel like there are certain supports you really need and want, and I'd be happy to try to think through with you offline on how we could potentially build some of those for you or make some of those connections. And then lastly, remember, language matters. How we talk about this yes, Deanna, you talk about compassion fatigue, and we have to be empathetic to that. We all get tired. Everybody gets sad and mad and angry and happy and glad as well. And so talking about that, there is no solution to the opioid crisis. There are solutions. And so how you can carve out your little niche and work in there is really as important as trying to go through these giant changes all the time. Sometimes it's the little things that matter. Don't just get on the bus. Don't just try to go connect with any hospital or health system. Figure out, spend some time critically doing a stakeholder analysis. Who are the people of influence? Who are the decision makers? Who are the people that know those decision makers? And how do you work a channel and slowly get to where you need to be? It's not pick up the phone and call the CEO, oh my gosh, the hospital won't get back to me. It may be you have a friend who's a licensed clinical social worker at the health department who has a friend who's a licensed clinical social worker at the hospital who works with a care team at the hospital who can then connect you with the ED director who will take a conversation with you, who then brings you to the opioid safety committee at the hospital, who then usually has a C-level person there, and it took you 5 months to get into that room. Own your space, but don't crowd others. Make sure that you are telling your story, but don't drown out the voices of other people. Not every intervention has to change the world. Like we talked about with the pebble in a box, how we collect data and how we share information and how we think through connections, it doesn't have to be life-changing every time. And the most important thing, given the state of North Carolina and given the amazing work that's also happening, despite all of those challenges, we're doing amazing things. But compassion, trust, and benefit of the doubt go a lot further than we're willing to admit. And so how we trust and how we give benefit of the doubt to those that have been challenging to us is going to be the biggest marker of success in building those bridges, I think, that you all have moving forward. So with that, again, that is my contact information, and I will open it up for questions and comments for the next little bit. Jamie, if people, I don't know if they can raise their hand and ask their question vocally right now, or if it'd be easier just to do it via chat, but I'll take them all.
I believe the chat and Q&A box will be the most efficient.
Okay, great.
Also, as individuals collect their questions and thoughts, upon leaving the webinar, you'll be asked to complete a short survey. So please do so. And I will also include the survey link with the handouts and webinar link, video recording link later this afternoon via email.
We'll give people a couple minutes, and if not, then we may get out a couple minutes early, which is not always the worst thing. But we have until 11:30, and I'll be here till 11:30. So.
Jay, Michael asked about the environmental strategies bullet point in terms of the perspective of environmental strategies.
Yeah. Hang on one second. Let me pull up something on my end to help me guide that. Michael, I think a lot of what we've talked about is that environmental strategy. It's that kind of strategic plan on how do we influence others. Our opportunities, I think, hopefully through this, are really around, I'm trying to make sure I say this the right way so that it makes sense, are really around leveraging our strengths to support the institution's goals. So, for example, if each of your health systems have, and frankly, they have goals for how they are going to solve this. It's a little naive. It may be a bit audacious, but looking and understanding that and thinking about what strategies you're using in your current work and what your kind of logic model dictates, you may be a key component to helping them achieve that. And so that would be one opportunity to reach out through their efforts. Yeah, there's a lot. We recently, there's a lot. I'm going to do Patty's question, and then I'll get Cedars on the vets. Around prescribers and pharmaceutical training, long-acting versus short-acting, there's different reasons to use different ones. We actually worked with a lot of pharmacy benefits managers and some others on the new workers' comp rules that just were recently approved, and it talks about when you can use certain types. I think there's some great information for clinicians on that. What's happening in the veterinary world, and if you know any updates they may be doing. Vets are acutely aware of this. However, they were carved out of the STOP Act in the initial bill, but we have been working hard to put them back in. So there's going to be some changes to the STOP Act either this year or in 2019, and one of those will be for veterinarians to start using the CSRS and start thinking through that. We've seen cases in North Carolina where people are abusing their animals to go get opioids for themselves, and there has been a concerted effort here in Raleigh to work with NC State and the veterinary school to train the veterinarians in the same manner that our new residents are being trained at Duke and UNC and medical school. And so there's actually some shared seminars and some shared meetings that they all go to together around this issue. But it is a population that's often not thought of. And the fact that they keep their medications at their clinics, not at a pharmacy, is of concern. And so we're trying to think through how they store and how they're regulated there. But that's a question that's above my pay grade in answering how they do that. Military. So the CSRS is statewide. Everybody uses the VA. Everybody. It is a universal tool to track prescriptions. If you are a licensed doctor in North Carolina, it doesn't matter where you work, you have to use that tool. However, the VA is doing some really unique things in terms of alternative pain management, and are actually kind of leading the way in some ways to think through how they can implement things such as yoga and massage or different types of non-traditional treatments into their military care. Another piece that military folks are working on and that we're hoping to partner with, and I'll be honest, that's one of the groups that we are newly engaging, is the VA system and military groups. That's been one that's been a little bit slower for us here at NCHA, but we feel as though it's important, is around the suicide risk and, mindfulness, all those different things. There's, looking at suicide risk of veterans and opioid use in conjunction, and what types of screening tools should be used. There's a great resource we are working with. It's called Psych Armor. It's free, and it is a training. It's just 25, 30-minute web-based webinars that you can just go download and look at, and it's training for providers and community-based on how to care for military personnel in different settings, how to hire military personnel, how to engage them in an impactful way, and it's a really cool project. It's a nonprofit out of California that I met, and they have over 250 courses that are just there and ready to be utilized by lay providers and others to better serve that population. It's called Psych Armor. And you can just Google it, and it's really great. Through TriCard and some other things, if they're on a long-term pain plan, there is thoughts about how they're revisited. But in terms of the large doses through the mail, I think right now there hasn't been anything to address that that I'm aware of. I think it's something that people are thinking through. How best do we do that to manage that patient? Even if they're sent through the mail and renewed, they're moving forward. We're hoping that 30 and 60 and 90-day check of the CSRS can be utilized before sending that, and maybe that will help think through. We're also looking at how we can utilize pain management contracts and potentially revisits at certain junctures to reevaluate the patient, and if there's other partners that could get engaged to serve that population, but that's still very, very high-level conversations, and I don't think we have a ton of movement on that, but that's a really interesting point. Interesting. I had not heard that they're doing larger and larger doses. So that is good information that I think I can take back as we work with our partners at DOJ and DOD. So. Well, great. I hope this was helpful and that you all feel a little bit more confident and can use some of this to build some connections with. So again, feel free to use the slides and contact me directly if you have any specific questions or just want to chat about your community. I'd be more than happy to help.
Thank you, Jay. And again, we will follow up with an email with the related documents and links later today.